Welcome everyone to this panel discussion on integrating psychosocial supportive care into the clinical management of patients with short bowel syndrome or SBS. As we get started now, I'm going to ask the faculty to introduce themselves.
Sure. Hi, everyone. Thanks for being here. I'm Jessica Allen. I am located in Birmingham, Alabama. I am an assistant professor of psychology, and I primarily am in the discipline of caregiving and quality of life research. But I'm also here as someone who has a 3-year-old who has short bowel syndrome.
Hey everybody, my name is Claire Brandon. I am a psychiatrist in New York City, and I focus primarily on gastrointestinal psychiatry. So working a lot with patients who are trying to deal with medications, support around things like short bowel syndrome, and just trying to help cultivate awareness about the mental health impacts of this disorder. So thanks for having me.
Hi, everyone. My name is Shannon Chang. I'm an associate professor of medicine at NYU Langone Health. I practice primarily in the inflammatory bowel disease space, so Crohn's disease, and I'm the director of clinical operations at our IBD center.
Everyone, welcome. I'm Dr. Debora Duro, Program Director, Pediatric GI at Broward Health, a Sala Foundation here in Fort Lauderdale. I'm actually a medical director of FIRST, Florida Intestinal Rehabilitation Support and Treatment Program. It's my main interest to deal with kids, children with intestinal failure, and to help them with the community with the program. Thank you.
Hi all, my name is Shannon Hourigan. I'm a clinical psychologist, and I'm a staff psychologist at Boston Children's Hospital and also an instructor in psychiatry at Harvard Medical School. I work with the short bowel program at Children's Hospital, the Center for Advanced Intestinal Rehabilitation, where I work with kids and young adults into sort of early adulthood around all sorts of issues related to managing the emotional and behavioral impacts of short bowel syndrome. Thanks.
Hi, everyone. My name is Swapna Kakani, and I am a short bowel syndrome patient advocate. I was born with short bowel syndrome 32 years ago and have experienced most of the care continuum and management of the disease in the last 3 decades, and thus now have become an advocate in the rare disease and short bowel syndrome space. Thank you.
Hello, I'm Jacklyn Stellway. I'm a pediatric psychologist in Portland, Oregon, and I work with patients across pediatric GI and all the different areas. My work in short bowel is primarily with kids with Crohn's disease and other forms of IBD that have led to short bowel.
Start with Dr. Allen.
Yeah, it's a great question. It's an important question. I think the thing that I'll speak to is something that we see here locally in the Birmingham area, which is that we have a pretty established intestinal rehabilitation program at the pediatric level, which means that psychosocial support is pretty well established, both at the Children's Hospital, but also in our broader community. And we're well connected to those resources. However, and I know Swapna could speak to this as well, however, when folks kind of start to move into teens and even later into adulthood, there's only just now a transition program, and some places don't have that at all. Ours is very new, and it's a catch-all for any pediatric disease or illness. So the providers on the adult side that we're kind of bridging now into adult care from both a psychosocial perspective and on the physical health side really struggle with, when do I become an adult patient? Who's part of my team? Who's part of the handoff in that process? And how do I best get my needs addressed? So maybe we felt really supported, and then kind of perhaps in some ways feel like, okay, I've been left to kind of deal with this or navigate these waters on my own.
Great, thank you for kicking us off. And Swapna, let's hear from you.
Yeah, Dr. Allen, that was a great segue. Personally, I did not go through any transition of care, given that I was transitioning in the early 2000s, and there was no concept of transition of care in the program that I was at, and also there wasn't transition to an adult program at the time. So as Dr. Allen said, a lot of times, unfortunately, because of that, we end up getting left behind and trying to figure this out on our own. So in my own experience, I've had to go out of state for adult care to another multidisciplinary team that focuses on short bowel syndrome, TPN management, and other parts of disease management. And so that's 2 hours away, out of state. Telehealth is not approved, etc. And then I now have a multidisciplinary team that I call my pit crew in several different states, with surgery in one state, dietitian in another, home infusion in another, and then all having to work with a local team, because as important as a multidisciplinary subspecialty team, it is important to have a local team that can take care of you close to home, especially in these pandemic times. And so a lot of times as an adult, we have to think about ownership of care, to be able to communicate our needs, being able to kind of accept that this is for the long haul, and what do we value, and being able to advocate and being accepting of that we could be the rare case, and that we are kind of going through uncharted territory. A lot of times I'm left at, okay, I'll figure this out on my own, even with the great team that I have today.
Thank you so much for those comments. And Dr. Stellway, we'd like to hear your thoughts.
Yeah, I think you both mentioned so many important pieces. And I'll just mention that, navigating the healthcare system with short bowel, there's just so many, the complexity of all the resources and supplies and everything that needs to be coordinated, in addition to all of the different subspecialty providers, as Swapna was mentioning, all the different providers to schedule appointments with. We really want to help young adults feel that they know how to navigate those systems. And, there is a lot we can do on the pediatric side to kind of screening adolescents and young adults in terms of how much they understand what their healthcare needs are, how to make appointments, how to pick up prescriptions or contact pharmacies. And the more we can prepare them and kind of encourage and support and challenge them to be taking on those responsibilities in pediatrics before they have this big transition to adult care where they might be left behind, I think we can really support them ahead of time to prep in that. And I really like to talk with families about, what are parents currently doing in healthcare management that the adolescent might be able to take on. And so kind of challenging an adolescent to say, what would you like to be able to learn how to do? Do you want to learn how to call the pharmacy yourself? Do you want to learn how to schedule? Do you want to be more in charge of the supplies and the management of your different supplies and changes of bags and things like that? So I think it's really important that we're thinking about this on the pediatric side and the adult side, but as much as we can do ahead of time, preparing families for that transition.
Thank you, Dr. Stellway. So let's move on to the next question, which is, what can the medical community do to improve these transitions of care? And to start, if we could hear from Dr. Brandon.
Sure. Actually, it's a really great segue from what everyone was just talking about, thinking about starting in the pediatric realm and making sure that that transition has not just been thought of, the few months before the patient is going to be transitioning into adult care. I find that to happen in all realms of medicine, psychiatry as well, that we sort of don't prep the patient. And I think when patients from a very young age are going through these issues, they learn to understand the medical system as part of their family. So losing part of their family, losing part of their team can feel really, really jarring. So even considering some transitional psychotherapy treatment for these patients, thinking about ways that we can get them to be thinking about this as their own idea, even like it's an exciting thing to be changing to their next stage, their next transition of care, and actually having them set some of these goals for themselves can be really, really amazing to help them get invested and be part of the team, not just feel like they're moving along and they're on the conveyor belt of medicine here. So that'd be actually my biggest thing would be, of course, I'm a psychiatrist, but doing some psychotherapy and making sure that we're talking to these patients really early on, doing some motivational interviewing and getting them on board with these transitions and their families as well.
Thank you, Dr. Brandon. Dr. Chang, how about your thoughts?
So I'll start by saying that just like adults, which I primarily see adults, but just like adults, I think children are all different, and their age may not reflect how ready they are. And so we do speak with our pediatric gastroenterologists here, and we're in the throes of creating our own transition program for inflammatory bowel disease. And we have talked extensively about the pediatrician giving the heads up to the patient that, hey, when you turn 18, I want you to start, thinking about transitioning. And the one thing that I would say is it's not going to be just a one and done thing, So we have designed our transitions clinic to have the pediatrician there with the adult GI, and potentially, if the patient is interested, with our psychologist, or just at least to introduce. But the transition should be fluid. It's not going to be like on August 22nd, you will no longer see me and you will only see the adult GI. I think that is too much for most patients. I know that I myself had a pediatrician until I was about 26 years old, and he was like, it's just time to go. So I think that, all joking aside, the communication is key between the family, the patient, and the adult and pediatric teams. And I think that leads to the smoothest transition.
Thank you. And Dr. Hourigan, your thoughts on this question?
Yeah, I think another thing that that I haven't yet heard mentioned is the way that the pediatrician can, the pediatric team can really also start talking to parents about the transition of responsibility of, different aspects of managing cares to kids across childhood, where appropriate, having teenagers, manage feeds, or, like Dr. Stellway was saying, making phone calls and doing things like that. But really talking to parents as the transition of medical care is also a very normative part of becoming an adult with, a complex medical condition. And having them transition, is not unlike, the way that they take more responsibility with homework, with, other aspects of their own self-care, where they're seeking more privacy as they're getting older, and really framing this as something normative and supporting parents who are feeling anxious and frightened about the risks involved in letting go of some of those aspects of caring for their own kids, and thinking about ways in which the psychologist can sometimes help support parents in providing kids with that freedom and that autonomy and the ability to maybe make some okay mistakes, and learn from them in a way that's really structured and thoughtful with the whole team.
Great, thank you so much. So now let's ask, we'll ask Dr. Duro to start us off on this question. How about coordinating care around complex nutrition needs?
Yeah, it's a great question. I mean, those patients, like Dr. Chang said, they are so heterogeneous in the terms of, intellect and also with their care, right? So I think to empower families, to really to be part of the nursing, the home infusion, and to really see these patients in a chronic way, that this is not going to be just a couple of months or years, that is patients that are going to be for the rest of their lives. And therefore, the entire family, I think, it needs to be engaged. Education to me is key from the time that they are, as I see children leaving the first time the NICU after several months, to get those families. And even if the mother is still yet, the parents not ready to take care of the whole nutritional aspect and the central line and everything that involves the care of these kids, at least early on to start initiating this educational, I would say, momentums, where you go and you let them see what's right to do, what's wrong to do, and be part of the team very early on. I think this is key of success. And because I see some kids that when the parents are more engaged and really take care of those kids, they are the ones also that if they have the intellect to keep on going, they are still early on, being able to take care of themselves as well and to make some decisions. So I think the hospital part, transitioning these patients at home is a big momentum to every time they come back and forth to do teaching, and to help the families to navigate through this problem.
Thank you, Dr. Duro. And Swapna, your thoughts on this question?
Yeah, thank you. I mean, this is something I'm really passionate about, given that, so personally, I've been on TPN for 29 years and I've and tube feedings for 24 years and transitioned off and on and struggled with oral eating, and now I'm forced to do oral eating and G-tube feedings because I've lost options in terms of TPN. And so my first statement to anybody involved in care is maximizing nutrition and making sure you're pushing and advocating and helping, if you're in the psychosocial field, pushing your clients to advocate for best nutrition if they're getting TPN, G-tube feeds, or oral eating, and pushing the team to do the education, as Dr. Duro said. But also what's involved in this a lot of times is home infusion teams who deliver the TPN, who also are involved in the education and essentially are the liaison between the family and the doctor in the home setting. And there's a lot of resources from that side, and there's entities that are very patient-centered and to really ask the questions of those individuals and make sure you're maximizing supplies and care technique, and then even support organizations and meeting others like yourself. I've learned a lot about care technique, even actually from friends and other parents and support organizations, more than maybe even my local team that I started with. And then when it comes to oral eating, with the addition of short bowel syndrome and getting tube feeding and or TPN, it's very complicated, and every child and or adult is different in how much they can take in orally, depending on anatomy, physiology, and more. So even asking those questions and pushing, like, are there clinicians that can help with restrictive intake? Are there feeding disorder programs available within the hospital, outside of the hospital, private clinicians, actual full multidisciplinary programs? These are all things that I'm asking now, which is very too late rather than when I was a child. So really maximizing the nutritional needs at every stage of life and helping clients to advocate for that throughout the journey.
Thank you very much, Swapna. Let's move on to the next question, which is really around seeking mental health care. So some patients with SBS or their family members may be reluctant to receive care from mental health professionals. So how do you talk with patients about mental health care? And we'll start with Dr. Chang.
Right, so this is a very important question. Patients with SBS, they have incredible physical and emotional and cultural issues that may bound from their actual diagnosis. And it's important for us as providers, medical providers, to be able to assess and then also refer to a psychologist or psychiatrist when that is necessary. Something that, is important is being able to assess at each and every visit. So in our specific clinic, we use the patient health questionnaire, which has 9 questions. Everyone gets it at the outset. We check the score. And that's one quick way to assess it, before the visit. And then, if there is in the discourse of conversation some concern about anxiety, depression, coping, need for some help from psychologists or psychiatrists, I may elicit that during the conversation. And then if I think that patient needs some extra assistance, I might ask them if they're amenable to seeing somebody, because I think the very first part of a referral is to make sure that the patient is willing, because we can't send somebody to a mental health provider who is not willing. And if the patient is not willing, I try to assess their reasons for reluctance. It might be, very commonly, it might be cost or inability to identify a provider. And that might be insurance related or just somebody that is not just a general psychologist, right? Somebody who has expertise with somebody with chronic illness. There might be an associated cultural stigma with seeing a mental health provider, so that's a big issue as well. And then, you know, some people just think that when you refer to a psychiatrist or psychologist, you're just referring either to get them on medications or just to talk to somebody. And I try to, you know, suss out what they think is going to happen, because a lot of our behavioral health interventions like cognitive behavioral therapy or gut-directed hypnotherapy isn't what they're expecting to hear. And it can be very helpful for them to understand that I'm not just having them talk to someone, you know. And so that's how I kind of try to assess that reluctance and start the conversation.
Thank you, Dr. Chang. Dr. Duro, how about you?
Yes, I think they need to understand that a psychologist, part of the team, the multidisciplinary team approach in this modern world, you know, for programs that can have this resource is like as important as to talk to the dietitian, to talk to the pharmacist, to talk to the social work. You know, there is another member of the team. This is a great resource that we have. I tend to talk to my patients as, listen, you know, I think, imagine that you want to talk to your best friend about a situation that you have. Why not to talk about your child, talk to the struggles you go as a mother, maybe dealing with the family and this chronic little boy that needs a lot of attention from you, from the other children. So why not to get this stress out of your shoulder and have your best friend here in my office? Now there might be the psychologist. So I tended to approach them as this is part of a great team of professionals that will see your child from different aspects, that everyone is equally important, you know, for thrive and for the success of the journey. It's a journey. So and with the nowadays, you know, more literature and articles published in short gut, I tended to get some of them and even say, listen, this is not something new. Here we have now literature coming. We have, you know, and I give it to the parents, even the resources for them to see and be open for this kind of approach.
Great, thank you so much. So there may be other mental health care professionals in the community who want to get involved in managing patients with SBS. How can they make themselves available? It's an exploratory question. So Dr. Hourigan, if you could begin, we'd love to hear your thoughts on this.
Yeah, thanks so much. I mean, you know, listening to, you know, to this series, you know, familiarizing yourself as much as possible with all of, you know, with what is short bowel, right? What does it mean? What are the kinds of things that families are facing? You know, as a mental health provider who is embedded within the clinic, I am finding myself I ask questions all the time of the medical doctors, of the dietitians, of our incredible nurses. You know, I'm learning constantly. And so if as a mental health provider, you have the thought that you really need to fully understand this diagnosis, please know that that's not the case. You can't, right? You have your expertise in mental health and all the things that you have your expertise in, and you don't have to understand all those other things. If there's a local, short bowel program near you, you know, reach out to the director of that program. Reach out to the providers there and say, hi, you know, I'm a psychologist, I'm a social worker. I'm really interested in care of kids with this. I'd like to learn more. Could I come to your clinic? Could I come to some team meetings? You know, could we meet? I'd love to just get connected and learn more. I can't imagine somebody not saying, you know, you're getting an enthusiastic, welcome from that. So, you know, it's okay to be curious. I'm curious all the time. I'm always asking questions. It's one of the reasons I enjoy being in a medical center. It's because I get to constantly learn about new things, and just reach out and learn and ask questions and just make yourself available, and just connect.
Great, thank you so much. Dr. Stellway, your thoughts on this?
Yeah, Joe, thank you. I think that was such a great answer. I'm trying to think of what to add to that, Dr. Hourigan. That was so comprehensive. I think I was going to say the same thing, reaching out to local GI clinics, learning about what they do and how you might be able to be kind of become integrated within their clinic, even if you're not going to be providing services in the same setting, just learning about what they do. And I wonder if there's sometimes patient advocates like Swapna who would be willing to talk with you to learn more about what it's like to live as a patient or a person or even a family and parent with short bowel, learning from those experiences. I find a lot of families have really benefited from looking on like YouTube and different blogs or Facebook postings too. And just as families are learning about it, you can kind of learn along with them as a mental health provider. And I think understanding the condition, but just as Dr. Hourigan said, you don't need to fully understand it, but understanding what families are going through or patients are experiencing on a daily basis. I think something that I'm not sure has come up yet today is, just as much as navigating the medical system, how a person is navigating their daily life around friendships and school and work, scheduling things around feeds. Do I need to be home at 6 p.m. to start my 12-hour feeds? And understanding kind of how a person is just going about their life and how their healthcare is integrated into their daily lives as they're just trying to just be a person that is doing whatever based on their values, whatever they're doing on a daily basis. Better understanding that system too, I think is a really important way to be able to be supportive and available to families.
Great, thank you so much. Dr. Brandon, your thoughts?
Yeah, I think all of those are really great ways to get involved in GI care, and that's what my path was as well, working with a team at a big medical center and just starting to talk about the patients with those teams and pointing out places where mental health might really help those patients. But I also think that being in the community itself and being into organizations like the Crohn's and Colitis Foundation, finding your local Crohn's and Colitis foundations, to get a better sense of sort of what these patients are going through. Often it's run with patients or run by patients. You're meeting other doctors in that avenue as well. And I think it really helps to give you a good sense of the person themselves, right? Because in mental health, often we're talking about the person's entire life. And it's not something that, unfortunately, in medicine, we have the luxury all the time of talking about. So I think it's a really great way to get to know people and understand what they go through in their life on a daily basis, finding them in the community like Crohn's and Colitis, the Rome Foundation, different advocacy groups, or even going to conferences, potentially with GI practitioners or with mental health, with the like Academy of Consultation Liaison Psychiatry, where we focus on medically complex patients. So I would definitely suggest some of those outside of the medical center resources as well to get a good 360 view.
Thank you so much. So now we're going to shift gears a little bit. We want to hear about the work that Dr. Allen and Swapna are doing with something called the Gutsy Perspective. So Dr. Allen, if you could start us off, tell us about your work.
Oh, sure. Thank you for asking about it. The short version of this, and I'll speak quickly, and then Swapna can add certainly her perspective, but essentially a group of women who have kiddos with short bowel syndrome, who have lost a child, or who have short bowel syndrome themselves, found each other via social support networks on the internet. And we learned that, wait a minute, we have an epidemiologist here, and we have a MPH who is also a patient advocate, and we have a psychologist, and so on. So we had this group, and we realized that that we actually had quite a story to tell, and that we wanted to use our skill set and background to do that and do that work. So this Gutsy Perspective really started with a woman named Marie Newman. She is a project manager and researcher on a grant at University of Nebraska Omaha Medical Center. The project started as quality of life work, and our primary goal, we've met for a long time, and our primary goal after meeting and having lots of conversations is that we really are interested in doing research and advocacy with the mission of improving patient, caregiver, even clinician quality of life. And we wanted to do that by bringing those communities together. So patients, caregivers, and clinicians all working together on what are the research priorities in short bowel syndrome and what might be addressed from a quality of life perspective. So I'll have Swapna speak a little bit to some of the work we've done, but essentially we met right around the pandemic. And we're able to start collecting data really quickly. So folks are eager to talk about this, to talk about quality of life for them and their families and what that looks like, and what some of those needs are. So Swapna, maybe you want to speak to that a little bit.
Yeah, thank you, Jessica. So, and again, yeah, thank you, Joe, for letting us talk about this. So yes, it's an initiative to study quality of life in the short bowel syndrome population. And as Jessica said, very collaborative, addressing both the patient families as well as educating and getting the needs from the clinicians, and making sure as public health professionals and academics, giving back the information and data to the patients and families in the layman terms and understandable way. So we have done exploratory studies with the community already and have published our exploratory data, part 1, in the Journal of Pediatric Surgery last fall, and are developing for the first time a quality of life tool specifically designed for the short bowel syndrome population that will be launched to a medical population for the first time this summer. So please stay tuned. We have a website and social media. We're moving forward, but yes, really proud of us that we only met in 2020 and all over Zoom, and all of us have not met in person. I've met Jessica because we're both Alabamians, and met some other people individually, but we all as a group have never met in person.
Great. Well, thank you so much for sharing about the work that you're doing, and we're eager to follow along. We're going to move on to the next topic, which is just around a group, a community, or website, or other example that's been a valuable resource for helping patients, their families with SBS, find psychosocial support. And there could be a variety of different examples. So to get us started, I'll ask Dr. Brandon to just pick one.
Okay, ooh, that's a big question to just pick one on there. So I think, I'm going to go with actually just from a clinician and community perspective, I'm going to go with the Rome Foundation because we haven't talked a ton about this yet. But the Rome Foundation has tons of resources for doctors, clinicians, patients as well. And it's a great resource to help find psychologists, psychiatrists who are working in this field. It's got a lot of great documentation. It's got links to papers. It's got support and stories about patients. And it really, I think it helps go to show that people aren't alone when they're looking for this psychosocial support and they're looking for resources. And it can be a great starting place to kind of jump off from, to just feel like, you can start finding your community and you can start finding some support and some help. So going with Rome Foundation.
Great, thank you. Dr. Chang, how about you?
So I did query our staff psychologist about this because I'm not exactly the expert on this, but she did point me towards the American Psychological Association. You can search by state for providers. So that's one. And then from the GI standpoint, there's a joint venture between GastroGirl and the American College of Gastroenterology, something called GI On Demand that you can actually sign on to or request access to. It has a lot of educational materials about not just SBS, but chronic GI illness and coping mechanisms. And then also there's a way to sort of search for providers who have an interest in chronic illness. So those hopefully are two that to add to the list.
Thank you. Dr. Duro?
So I tended to point my patients to really participate more from the GI kind of disease standpoint with the Olay Foundation. I think the Olay Foundation brings, an environment, is a community that is valuable to everyone. I mean, children to adults, to family, to patients being their own advocates like Swapna is, I think is amazing. And I even have, supported some patients to really apply for the fellowship they have, which they can be, granted a meeting. They can go once a year to whatever OLA meets. They can travel and get this grant and apply for the grant. I had several patients that had been, and they absolutely said it was was a changing point for them to see a community of people there that are a foundation just, focusing on short bowel syndrome.
Great, thank you. Dr. Stellway.
Yeah, thank you. All these organizations are great places to go, but I think I might answer this from a slightly different perspective, from the social media perspective. And I think I mentioned earlier YouTube videos, and specifically the Takeda YouTube channel has some really, really well put together patient stories. And I think that can allow families to understand what others are going through and to feel validated, and kind of when they're able to see their story shared by someone else, recognizing that those similar experiences exist across different families, different ages. Everyone from babies through adults have stories on that channel. And I'll mention one more just because I've had a lot of teenagers tell me lately that they have found validation and support through TikTok. And I caution kids and families of how to use that in a really healthy and safe way. But several teenagers have been telling me recently that they've kind of explored this avenue with looking up different hashtags and finding that it's really supportive, and sometimes even making connections through that community. But even just seeing, again, that other people are going through this. I'll just throw that out there because I've had a lot of teenagers recently really finding a lot of support through that community.
Thank you, Dr. Stellway. Swapna, how about from your perspective?
Yeah, I agree with what everyone has said, and really, like the OLE Foundation kind of changed my life, and I met for the first time fellow young adult women who were also wearing a TPN backpack and had tubes and IVs. And so actually a couple of us have now become the girls with gutsy girls with good for nothing guts, and we're going on a girls retreat in 2 weeks and do one every year. So one is do the best you can to find other people like yourself. It's invaluable for people who just get it. And Jessica and the Gutsy Perspective group also serves as that kind of support. And then to get it from multiple ways. I mean, support organizations, do your best to try to go to the meetings or log on through Zoom. But also in the last 2 to 4 years, I've actually found a lot of support and validation through Instagram, similarly through TikTok, and even some Facebook groups. But of course, with anything with social media, you do have to be very careful. And in the part 2, I purposely put certain hashtags and specific organizations to help people hopefully navigate the social media to find certain accounts. But it has been really validating not only to see short bowel syndrome, people with short bowel syndrome and their stories, but also people with ostomies, people with IBD, people with other psychosocial distress, and really I learned the concept of flashbacks through social media, because there's a lot of terms that I was going through that I had no idea really had a name for, and then gave me the confidence to bring it up in therapy. So I really do encourage exploring safely social media as well.
Thank you. And Dr. Allen, your thoughts on this?
So you said give one, so I'm going to give one from the academic side and one from the caregiver side. From the academic side, I just want to say I'm going to speak from a PEDS perspective, which is actually the websites and newsletters from 2 places, Family Voices, and also the Department of Maternal and Child Health have been really, really helpful. A lot of the questions around how do I get access to psychosocial support, or even some of the perhaps psychosocial support needs questions, are frequently around cost, and those 2 places have been really helpful. And they're not short bowel specific, but they are short bowel included, right? So how can I kind of, as just a person in the community or a professional, use those resources to kind of help me navigate some of those questions? From the caregiver side, 2 things. we find each other and we will find each other largely on social media. There are Facebook support groups. You do want to caution your folks because they shouldn't certainly be getting, of course you know this, but they shouldn't get medical advice in those places. And they also should be very cautious about some of the mental health, perhaps, advice that they might get there. But in terms of peer-to-peer social support, it's really great. And one of the things that I've discovered is in my own town, I did not know, but there are respite programs for caregivers that will pay for my husband to go on a date night, and they will pay for someone to babysit my kids. The one with short gut and the one without. So those kinds of things, respite type programs, I think maybe with some chronic diagnoses that you feel like you're the only one that can manage it, it may be hard for those family members and patients to be willing to relinquish that. And so I think pointing them towards those resources can be very helpful.
Great, thank you so much. We're going to move on to the next topic, which is really the ideal model for providing psychosocial supportive care. And we know that the current healthcare system is highly fragmented. So if there was sort of this ideal model, we think about, who should be on that team and how are patients being referred and how is all of this coordinated? So I'd like to ask Dr. Brandon to start us off. Dr. Brandon?
Yeah, absolutely. So I've seen this model a few times before in ways that I thought was almost ideal. So I'll give you my absolute perfect idea, and anything in that realm I think is probably a great place to be. When the patients are complex with SBS and they really deserve to have a lot of support and a lot of transitional care, often what I see is that a social worker is immediately attached to that patient in the clinic. And that's really helpful because it starts them off by basically saying, hey, we have a navigator for you, both for mental health as well as for your appointments, and trying to help you to figure out all the ins and outs of this really, really complicated world. And then those social workers are also, they tend to be, at least in the short term, they could be helpful for providing some psychotherapy, and they can also help to elevate to another level. So if they need actually a psychologist to be working with or a psychiatrist to be thinking about medication consults, those social workers are sort of the abilities to, they have the ability to sort of alert the whole team. And what I find is that when those teams with the GI doctors, with the social workers, with psychology and psychiatry are all regularly meeting together and really triaging this list of patients that needs more care, less care, who's doing well, who's in the hospital right now, what's happening on any given day, those patients tend to, I think, get the best care. The team feels really supported by each other, which is incredibly important with SBS and any other kind of complex medical condition, because it can be, doctor burnout as well. And so I think that when you have this really comprehensive team, a liaison for the patient going through the whole system, and everybody sort of collaboratively working together and seeing themselves as a unit, that's my sort of perfect scenario for working with these SBS GI patients.
Great, thank you so much. Dr. Allen, your thoughts on this?
Yeah, thanks. I'm actually really passionate about having a representative from palliative care involved in some capacity. That could be very early in the journey for kiddos, or even into adulthood. I just think that that's something that requires the team to have lots of conversations about what is palliative care and what does it mean. It will scare some of the families, I think, originally, and they might want to decline it at the beginning. But I think that it can be very helpful. One of the challenges with short bowel syndrome that we didn't talk about today is just kind of the both physical and emotional pain that's involved with short bowel syndrome, and palliative care can really help with managing and being part of that conversation. So I think that's really important. In the perfect world, there would be a liaison. So basically, this is the person that's the speaker on behalf of the person's medical team, whether that's communicating with their school counselors, or they're kind of the go-between person for their local providers, but kind of who's your point person, whatever that looks like. That's not just your medical liaison, but that's also going to speak to those outside communities. So yes, and I guess is what I would say. If I could have a unicorn, right, we would have nutrition and medicine and social work and nursing and a pharmacist. But the two that I feel pretty strongly about are palliative care, and then someone that's your liaison or your point person.
Thank you, Dr. Allen. Dr. Duro, your thoughts, things that you would like to add?
I just feel like social works, they carry so much responsibility. They are, you know, they have so many hats with this situation, trying to be like an octopus, right? Coordinating everything with the physician too. So I think hospital-wise is very important. I mean, to get early on for any new patient, you know, so they know again that it's part of the team to have a psychologist. So to have during inpatients, sometimes the kid's coming with fever, or is a new patient leaving the NICU, going home and then bouncing back to the hospital, and you start this whole care early on to introduce that to the family. And outpatient again, outpatient, if you have the resource to be just as you go yourself to talk to the patient, the dietitian, and after introduce as part of the team to having the social, the child psychology, and they can then address whatever is going on and follow up and make those appointments aside and continue chronically, like following those patients. I think it's very important to be as a team early on, inpatient and outpatient.
Great, thank you. Dr. Hourigan, anything that you'd like to add from your perspective?
Yeah, you know, and thinking about what's the ideal model, I think when I'm reflecting on it, when I was reflecting on this question, I think the ideal experience I had was when I was a trainee, you know, when I was an extern before getting my clinical psychology PhD. And the reason I think that I was able to have this ideal experience, and I'll explain what that was that I was not as expensive, right? And I think that in order to create the ideal psychosocial model for families, I think hospitals and systems really need to think differently about how care is reimbursed and how we're putting value on the time of different professionals. So the experience that I had, and this was actually not in a short bowel group, it was in a cystic fibrosis, you know, subspecialty clinic. But I spent about 20 hours of the week within this clinic. I would attend all clinics. I would be part of the case court, or you know, the case planning in the morning with all the providers, talk about who's coming in, what are some of the challenges. I would identify people I wanted to check in with, but people got to know me. I stopped being scary as a mental health provider because they knew me. They saw my face all the time in clinic. I was just, you know, I became just as familiar as the dietitian, as the pulmonary therapist, as, you know, their doctors, everything else, right? And then when folks needed I could pop in and do some quick targeted work with families. They just needed a little behavioral tweak, and I could help them a lot. In that moment without having to get a prior authorization, without anything like that. And when families needed more help that made sense for outpatient care, then I could see them within an outpatient therapy model. But being able to get that buy-in from families, to get them to know me, you know, I was there for about 2.5 years. I think I was able to provide an incredibly high level of care for families because I was able to spend so much time getting to know all of these facets of their care. And I was just somebody who was familiar and not frightening. And I think the models that we have now are often really restricted by the payment systems and the way that we think about, you know, about care. And I think that's something that we need to consider.
Thank you so much. Swapna, we'd love to hear your thoughts on this question.
I agree. I think ideally it would be somebody within the clinic system. In my life, I've never seen an actual psychologist within the clinic. And psych was called on me in the hospital, and I thought it was punishment, or I was in trouble, or I was getting called non-compliant in some way. And it was not a positive experience. So there is definitely the stigma, and so I agree that if it can be started early on in a non-threatening environment where they are an integral part of the team, which now I have outpatient therapy, which I personally had to start on my own, and they are an integral part of the team, but they're like external, very much not part of the short bowel syndrome multidisciplinary team that I have, which is good and bad. So if there could be somebody within the clinical team that really understands the short bowel syndrome management and the identity that changes as you have complications, as you don't have complications, and can match the clinical model, would be very helpful, versus I feel like I'm still the coordinator and educating the therapist as I go through therapy.
Thank you so much. Dr. Stellway, would you like to add your thoughts on this?
I'll just very briefly emphasize the reducing stigma and introducing services early on. I think in an ideal model, the psychologist or social worker or mental health provider in whatever fashion is there in the first visit when a family is becoming integrated into a health setting, whether it's inpatient or outpatient. The person is there, the family is seeing their face, just as others have mentioned. And then I think an annual visit with a multidisciplinary team is ideal too, just to keep checking in.
Thank you so much. I want to remind the audience too that if you have questions you'd like to ask, you may submit those questions through the question box. So you can just click on that and type your questions in. In the last several minutes, we're going to address one more topic here, which is some patients may need to travel to receive care at different facilities. What are some ways to help patients and their families coordinate care? And to start us off, I'd like to hear from Dr. Allen.
Thanks. Yeah. Well, we were just hearing about Shannon's rotation and the CF population, and I'll just say that's a group that I think does this really well. I don't know that maybe hospital, but they do this really well. And one of the things that they have done is through funding via this the Cystic Fibrosis Foundation, they're actually able to train family leaders who are sometimes there are a couple of pulmonary centers in the United States where the family leaders are basically advocates that are part of the team process. And so they might sit down with the healthcare providers and have a conversation and say, so-and-so is coming, they live this far away, and you've got them coming on the day after they're seeing allergy, or the day before they need to go see whoever else. And so what they've done a really nice job is they've been able to work across the different healthcare subspecialty clinics to make sure that they're not just worried about their own, are you seeing GI today? Are you seeing the pharmacist? Are you seeing so on? But when do you need to see allergy? When do you need to see so on and so forth? So they've done a really nice job about that. I think also, if we can also keep in mind that some patients are maybe even coming in, not only do they have appointments at various facilities, but they also need to meet with their home infusion companies, or maybe there are drop-offs or pickups. So asking those questions would be really helpful, maybe even just by starting and saying, who else follows you and when do they typically follow you if it's local? So that just asking that question to see if we can work with them. So I know that there are restrictions, but just trying to find out. The social worker usually has, as Dr. Duro said, many hats, but in part of that role, they typically know who all are they seeing and how far are they traveling from. Finding out, are you gonna, my team, actually, my kids team called recently and said, hey, we know you live in town, but we have a baby that's coming from 4 hours away who, if we move your appointment, they won't have to hook up TPN into the car. Would you be okay with that? Does that work for you? And and the answer was yes. I've been that person, so please, can we make that work? So I think just thinking outside of the box in terms of what are some of their needs and how can we better address them just by asking the question.
Great, thank you, Dr. Allen. Swapna, your thoughts on this issue?
Yeah, I think this is a huge reality, especially for adult patients, as our the care in the short bowel syndrome world is a less wholesome, a little more fragmented in compared to the pediatric multidisciplinary centers we have. And actually, one of the biggest advocacy things I do is help people decide or kind of guide them in trying to figure out, is it time to go out of state or to another multidisciplinary care team, and figuring out the questions and what is involved in getting there. So I think in ways of helping, and this is pretty complex, is that one is alleviating stress. I mean, this can be a very stressful situation for any family, leaving town, leaving what they're comfortable doing, what they now know is normal and what could be perceived as safe, to then do this whole thing, maybe explain 3 years of their life or even 20 years of their life, or even just 2 years of a very acute diagnosis of short bowel syndrome suddenly to a whole new team, and trying to get them to understand where they've been, where they want to be, and where they are now. And so guiding their coaching them through that, or being more comfortable in venturing into something new, and the value and hopefully progress they could get from going to a different care facility. And then there's a sense of control in this process of where you do end up coordinating and trying to keep all the pieces together. It does fall on the patient and family, because at the end of the day, we know ourselves best and we know our story best, and we have to be our best advocates. But we also need to let clinicians do their job and work together as a team. And so being able to, again, say, okay, focus on Monday, and then take care of your child or take care of yourself the rest of the week, and let hopefully the medical system, that is difficult to navigate on its own, coordinate. And so again, spacing between focusing on this versus getting obsessed and overwhelmed over it is just the surface of this situation.
Thank you so much, Swapna. I want to thank the faculty for your time, for your contributions. I want to remind everyone that we have recordings from part 1 and also from part 2 available on the shortbowelsupportivecare.com website. And then this will take you to the AKH-CME website, where you can claim continuing education credits. The videos and the recordings are also available on YouTube for people who want to be able to share this easily with their colleagues. But really, on behalf of the faculty panel, and we just want to thank you for joining us for this program. We encourage you to watch part 1 and part 2 if you missed those. And we will also be doing some more outreach and dissemination of the education, as well as tools and resources. And we'll be putting those on that website. So some other future activities we have planned include some Twitter chats and some Twitter outreach. And we'll also be doing some things on Facebook. So just stay tuned by going to the website and visiting and keeping up with those updates. But I want to thank the faculty again, and thank you all for participating in today's program.